Medical news from European Heart Journal. Plasma infrared molecular fingerprinting stratifies residual risk in coronary artery disease and reflects clonal hematopoiesis-associated biology. A novel blood-based infrared spectroscopy test can sort patients with established coronary artery disease into distinct mortality risk groups, doing so more accurately than the current guideline-derived SMART2 score and without the need for genetic sequencing. This matters because even after optimal medical therapy, many individuals with CAD continue to die from cardiovascular causes, and clinicians lack a simple tool that captures the hidden biological drivers of that residual risk. Coronary artery disease remains the leading cause of death worldwide, and despite widespread use of antiplatelet agents, statins, and lifestyle counseling, a sizable proportion of patients experience recurrent events. One emerging contributor is clonal hematopoiesis of indeterminate potential, CHIP, a condition in which somatic mutations in blood-forming cells expand with age and have been linked to inflammation-driven atherosclerosis. Detecting CHIP currently requires next-generation sequencing of dozens of genes, a costly and time-consuming process that limits its routine clinical use. The investigators therefore set out to test whether an infrared molecular fingerprint, IMF, of plasma, capturing the aggregate biochemical composition of circulating proteins, lipids, and metabolites, could serve as a rapid, inexpensive surrogate for CHIP-related risk and improve prognostic stratification. The discovery cohort comprised 1,341 patients, mean age 73 years, 76% male, with angiographically confirmed CAD who were followed for up to 10.7 years. For each participant, the researchers obtained a plasma infrared spectrum, detailed clinical variables, and targeted sequencing of 13 genes most frequently mutated in CHIP, including DNMT3A, TET2, and spliceosome components. Using penalized Cox regression, they built a risk model that combined the IMF signature with age, IMF plus age, and compared its performance against the SMART2 score, which integrates conventional risk factors such as age, sex, diabetes, renal function, and prior events. Model discrimination was evaluated with the Concordance Index, C-index, while reclassification, calibration, and decision curve analyses assessed clinical utility. External validation was performed in 3 independent samples: pre-CAD2, 474 participants, the population-based CORA cohort, 3,044 individuals, and the Lasers for Life cohort, 2,123 participants. In the primary analysis, the IMF plus age model achieved a C-index of 0.79 for all-cause mortality, significantly higher than the SMART2 score's 0.74, p less than 0.01. Net reclassification improvement was also statistically significant, indicating that a meaningful proportion of patients were correctly moved into higher or lower risk categories. Decision curve analysis demonstrated a superior net benefit for IMF plus age across a wide range of threshold probabilities, suggesting that its use would lead to better clinical decision-making. Kaplan-Meier curves stratified by IMF-derived risk tertiles showed stark differences in survival. Mortality at the end of follow-up rose from 3% in the low-risk group to 27% in the high-risk group. Log rank p less than 0.001. Notably, the high-risk stratum was enriched for carriers of CHIP mutations, especially those affecting spliceosome genes, implying that the infrared signature captures biologically relevant clonal alterations. In the 3 validation cohorts, the IMF-based risk categories reproduced the expected gradient of mortality and were associated with comorbidities such as chronic kidney disease and heart failure, reinforcing the generalizability of the findings. These results suggest that plasma infrared molecular fingerprinting could become a practical tool for precision secondary prevention in CAD. By identifying patients with a high residual risk that aligns with CHIP biology, clinicians may consider more aggressive anti-inflammatory strategies, intensified lipid lowering, or enrollment in trials targeting clonal hematopoiesis pathways. Moreover, because the assay is rapid, low-cost, and does not require DNA extraction or sequencing. It could be integrated into routine outpatient visits, potentially supplanting or augmenting existing risk scores that rely solely on clinical variables. The study's limitations include its observational design, which precludes definitive conclusions about causality, and the fact that the infrared signatures were derived from a single platform, raising questions about reproducibility across different spectrometers. Additionally, while the association with CHIP was strong, the assay does not differentiate among specific mutational clones, and its performance in non-CAD populations remains to be explored. Nonetheless, the work provides compelling evidence that plasma infrared spectroscopy can serve as a scalable, biology-driven risk stratifier, opening avenues for more tailored management of patients who continue to face high mortality despite standard secondary prevention. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.